Hello, doctors. This is Dr. Brony once again. We are here to study, and I really encourage that you join us from wherever you are. If you're also seeing this, please send a link, whether you are joining us on Facebook or on YouTube. Just send the link to your friends so that they can also join us right away. We are about to take off. So, I just want to make sure that everyone is ready to go. So look, let me know, where are you joining me from? 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 So that I'll know who is with us today. Please just let me know, where are you joining me from? Where are you joining me from? Okay. And before we get in, I think for some time now, we've not really talked about the study planner. So I want you to know that you have this study planner for you. We've made it available for you, where it covers all the MCC objectives. So if you want to, prepare for your exam effectively, just, let me know. I will send the link to you. In fact, what I will do is, let me put the link in the comment section right away. Okay. So I'm putting the link in the comment section right away so that you can download it. You can go there and download it. Okay. Republic of South Africa. Beautiful. So we're getting people join us from all over the world. And this study planner will help you. If you want to get a 6-month study plan, you've designed it there. If you want a 3-month study plan as well, it's also there for you. Okay. So please just click on the link I'm putting in the comment section. You'll see it on both on Facebook and on YouTube. Just click it. Let's go. Just download it. Let's go. And as usual, we're going to deal with some very important concepts. These meetings, we use them to do deep dives. Wow, we have someone join us from England. That's interesting because it's very late in England, and that tells me about the sacrifice doctors are making to pass this MCCQE1 exam, staying up late just to make sure that they learn and form study groups and do whatever they have to do. So I really appreciate that, and that's awesome. And we also have someone from South Africa. What's the time in South Africa right now? Dr. Lusamaki. What's the time in South Africa? Currently, it's 5:04 in Saskatchewan. And I think it's 7:04 in Toronto and Ontario. So you know what? Just let me know where you're joining us from so we can be of help. Okay. So I'm very glad, I'm very glad I see I'm very glad that I see that people are joining us live right now. So please just let me know if you're still needing the link to the checklist so that it can help you with your studies. But today we're going to just dive right in and then get our studies going. Okay, beautiful. We get people join us from Ghana. It's around 11 p.m. in Ghana. So you know what? I'm very glad. Wow, 1 a.m. in South Africa, and people are up studying for the QE1. That's beautiful. So that's the link. If you check your YouTube and your Facebook comment sections, you'll see them there. Okay, you see them there. So that is awesome. That is awesome. So let's get the ball rolling, and we will see what we can do today. So today's class is going to be on, as you know, let me see. Today's class is going to be on, as you know, approach to how to ace the low abdominal pain syndromes. The last time we did the upper abdominal pain syndrome, and looks like the response we got told me that people want to really get this thing right. So that's why I was like, okay, sure, then let's get into it and do it. So how to break down the differentials of low abdominal pain syndromes. Okay, and as usual, as you've told me in the past, I'm going to start the class with some questions so that you can test yourself, and then after that we can get in and break some concepts down. So I'm going to start by reviewing some concepts and some questions, and if anyone also wants to join me live, you can do that. I'm going to send the link so that maybe you can read some of the questions for us, okay? So we can all get things going. So I'm putting the link in the comment section. If you want to join me live, just make sure that your video is on. Last week, we got someone join us live and it was awesome. So if you want to join us live, just click on the link. I've put it in the comment section. Click on it and then let's go, because we're going to start with some MCQs. And the reason why I'm focused on MCQs now is because of the fact that the exam is changing. Okay, so the exam is changing. So we're going to do some MCQs, and then after that, we go into a deep dive and deal with some of the concepts. So let's start with the first question. As usual, if you want to join me live, just click on the link. I'm going to show you the link I've put in the comment section. That link, www.https. And then you just click on it. It will allow you to join me. We can only take a maximum of 8 people. Okay, so if you want to join me live, do that, and we'll take it from there. Okay, but I'm going to read the first question while I wait for people who want to join us. So, you have a 34-year-old female who presents to the emergency department with 2 days of left lower quadrant pain, low-grade fever, and diarrhea. Okay, this patient's temperature is 38.3, and her white blood cell count is 14,500. She denies any urinary symptoms. On physical exam, she has tenderness localized in the left lower quadrant without rebound or guarding. A pregnancy test is negative. Remember, we are dealing with low abdominal pain syndromes. What is the most likely diagnosis? Because there are so many diagnoses we need to be able to master. 34-year-old, emergency department, 2 days, left lower quadrant abdominal pain, low-grade fever, and diarrhea. Temperature is 38.3. White blood cell is 14,500. She denies any urinary symptoms. On physical exam, she has tenderness localized to the left lower quadrant without rebound or guarding, and the pregnancy test is negative. So what is your diagnosis? And we have appendicitis, we have Crohn's, we have acute diverticulitis, and we have ovarian torsion. And it looks like we have quite a number of people who are going for acute diverticulitis. So let's see, what does the jury say? And the answer is correct, acute diverticulitis. And it looks like almost everybody who is answering it is getting it right. And we have quite a number of people from the MedCognito class who are getting it right as well. I see Dr. Jackie Lou there. I see Dr. Isaac, all these awesome people. I see Dr. Neka. So these are people who are studying hard and, doing their best to get a concept. So what I like about these sessions are that in the long run, even though I'm quizzing you on one question, we also learn a lot from other conditions. Okay, so we said the answer is acute diverticulitis, and there's left lower quadrant pain with fever and leukocytosis. That's the elevated white cell count, which is highly suggestive of diverticulitis, especially in the absence of urinary symptoms or pregnancy. So you realize that we talked about the fact that we have to rule out pregnancy. And because it was ruled out that the pregnancy test was negative, now we can focus on that. Why is it not acute appendicitis? Usually, acute appendicitis will present in the right lower quadrant. So even by knowing the location alone, it can help you to break down some concepts. What about Crohn's disease? Crohn's disease typically causes right lower quadrant pain and has a more chronic presentation. Okay, so that is another thing. Acute appendicitis may have a more acute presentation, even though it is more localized in the right. Crohn's disease is more likely also to happen in the right, but that has a chronic presentation. What about ovarian torsion? Ovarian torsion can cause acute pain, but the lack of adnexal mass or significant gynecological history makes this less likely. So, if you want to break it down, the low abdominal pain syndromes, which ones are we going to see on the right? Which ones are we going to see on the left? In a board exam, think when you see in the left and then pregnancy test is negative, not much credence is given to, an enlarged ovary or something, think about acute diverticulitis as one of your differentials. Also, look at, are there any urinary symptoms? Is there any sign which is positive for pregnancy? Look out for those things. Now, acute appendicitis we learned will mostly on the right, but to be of acute onset, while Crohn's disease is also likely to be on the right mostly, but that has a chronic presentation. So that is one thing which will help you to to look between acute appendicitis and Crohn's disease. And ovarian torsion, look for that patient who probably has an enlarged ovary, or look for that patient who probably has, some gynecological thing going, or maybe some ovulation induction, because it can cause so many cysts to form, and that can cause the ovaries to become big and they can twist on themselves. Okay, so now let's go to the next question. And as usual, as I said, if you want to join me live, I'm putting the link in the comment section. You can join me, okay? You can join me. Just make sure that your camera is on, then you can join me, and then we'll just take it from there. But I'm going to read the next question for you. So you have a 52-year-old male who presents the history of fatigue and intermittent lower abdominal pain. His lab results reveal iron deficiency anemia. He has no history of gastrointestinal bleeding. Okay. He denies any weight loss, changes in bowel habits, or family history of colorectal cancer. What's the next best step in management? You have a 52-year-old gentleman. It looks like he's symptomatic of anemia. He's fatigued. He has intermittent low abdominal pain, and his lab results reveal iron deficiency anemia. What will you do? 52-year-old, iron deficiency anemia, low abdominal pain. What's your next best step? Are you going to initiate oral iron supplementation because the patient has iron deficiency anemia? Are you going to do a colonoscopy? Are you going to do an abdominal ultrasound? Or are you going to do a stool antigen test for Helicobacter pylori? How are you going to approach this particular case? What are you going to do? Doctors, what will you do? What will you do about this? How are you going to address this? Let me know. Let me know. How are you going to address this? So it looks like a lot of doctors are going for B, that they are going to, do a colonoscopy. And those on Facebook, I hope you are you are joining us as well. Those on Facebook, those in the Facebook group, those on the Facebook page, I hope you are joining us. Awesome. So what is going to be your answer? A lot of doctors are going for B. And the correct answer is B. Beautiful. So colonoscopy in older patients with iron deficiency anemia and low abdominal pain. What you want to do, so you see low abdominal pain, you see iron deficiency anemia, you see older patients, the first thing which should come into your mind is, hey, I need to rule out colon cancer. You should rule out colon cancer, and colonoscopy should be your next best step. Okay. What about the other options like initiate oral iron supplementation? While iron supplementation is needed, the underlying cause must first be investigated. So don't, just start treating things without knowing exactly what you are dealing with. So even though, it is good to give iron supplementation, it is necessary that you find out what exactly is causing this patient's anemia. And one of the things you want to do in somebody who is elderly, who has anemia, who does not have frank rectal bleed or anything, is make sure that you do colonoscopy. Okay. Now, what about abdominal ultrasound? This would not be appropriate test for investigating potential colorectal cancer. If you want to really, really investigate colorectal cancer in this patient, please make sure you are getting a colonoscopy done. What about the stool antigen for Helicobacter pylori? This is relevant for upper GI issues, not lower GI issues. Remember, today we are dealing with lower GI syndromes. So let's go to the next question. Doctors, please, are the explanations making sense? I want to know, are the explanations making sense? Are they making sense? And are they helping us to break things down, because I want us to use the questions to break the concepts down, and then after that we do a deep dive into the studies. Please, if it is helping, just type yes, 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 yes. I want to make sure it is helping. I want to make sure the explanations are helping. So if yes, just type in yes, 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 and let's go. If yes, just type in yes, 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 and let's go. Okay. If the explanations are making sense, just type in yes, 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 and let's go. Okay. Beautiful. Okay. Beautiful. So that is what we intend to use these sessions for. So every Wednesday, unless otherwise stated, I'll do my best to come online so that we can deal with some concepts and break them down gradually. So let's go to the next question. You have a 27-year-old female who presents with 3 days of right lower quadrant pain, 3 days, and diarrhea. She has no fever. She has no vomiting. On physical exam, there's tenderness to the right lower quadrant, but no guarding, no rebound tenderness. Lab tests show white cell count within the normal range. Pregnancy test is negative. CT scan did not show any appendiceal inflammation. What's the most likely diagnosis? A, ectopic pregnancy. B, Crohn's disease. C, appendicitis. D, pelvic inflammatory disease. What are you going for? 27-year-old female, 3 days of right lower quadrant pain, diarrhea, no fever, no vomiting, physical exam, tenderness in the right lower quadrant. CT scan did not show any appendiceal inflammation. Dr. Neka, please, you want to look at your answer again. You are going for C. You are going for C. That is appendicitis. You may want to check your answer again. Okay. Remember, CT scan did not show any appendiceal inflammation. Pregnancy test is negative. So with pregnancy test being negative, you ruled out ectopic pregnancy. CT scan did not show any appendiceal inflammation. You are literally ruling out appendicitis. So now you're left with Crohn's disease and pelvic inflammatory disease. Okay. And so which one will you then go for? Crohn's disease or pelvic inflammatory disease? And the answer will be Crohn's. Why? Remember that we said that, Crohn's may have, a protracted period of symptoms, right? And there's a subacute right lower quadrant pain with diarrhea. So Dr. Jagdeep, you went for D, which was pelvic inflammatory disease. But remember, this is a board exam, and I gave you pregnancy test is negative. Okay, sure. CT scan did not reveal any appendiceal inflammation, so that rules out appendicitis. Pregnancy test being negative, that rules out ectopic pregnancy. But then the patient has diarrhea, right? Diarrhea. So you want to see what is going on. And Crohn's disease is the most likely because there's a subacute right lower quadrant pain with diarrhea in a young person without any signs of infection or elevated white cell count. Because in pelvic inflammatory disease, I'm expecting the white cell count to be elevated as well. Okay, I'm expecting the white cell count to be elevated. So if I'm seeing that white cell count is normal, then I'll have to think about something different from pelvic inflammatory disease, something different from appendicitis, and pregnancy test is negative. So I'm going to think about something different from ectopic pregnancy. And in all this, the only one left will be Crohn's disease. Okay, Crohn's disease. Okay. Next question. You have a 44-year-old male who presents with low abdominal pain and painful urination for the past 5 days. His temperature is 37.8, and he has mild tenderness in the suprapubic area. Urinalysis shows positive nitrites and leukocyte esterase. What's the most appropriate next step? What's the most appropriate next step? What's the most appropriate next step? A, start antibiotics for cystitis. B, refer the patient for colonoscopy. C, perform a scrotal examination. and D, other abdominal CT scan. And doctors, while we are going through this, I'll suggest that make sure that you also subscribe to our YouTube channel as well. Okay. While we are going through all this, I'll suggest that please make sure you subscribe to our YouTube channel so that you can go back and watch these live sessions. Okay. Good. So what are we going to do? What are we going to do? Are we going to A, start the patient on cystitis, antibiotics for cystitis, B, refer for colonoscopy, C, perform a scrotal exam, or D, order an abdominal CT scan? Okay, so it looks like a lot of people are going for A. And the answer is A, start antibiotics for cystitis. Okay, because the patient's presentation of dysuria, suprapubic pain, positive urinalysis, which is consistent with acute cystitis and antibiotics, that tells me that antibiotics is what we should start. What about referral for colonoscopy? I don't think that is appropriate. Okay, that is the investigation we will do because we suspect colon cancer. But in this situation, no. What about perform a scrotal examination? You know, it would be necessary if the patient had any scrotal symptoms. But in this particular case we are dealing with, there were no scrotal symptoms. So I'm not going to do any scrotal, like I'm not going to perform a scrotal exam. What about ordering an abdominal CT scan? It is unnecessary because this patient only has, abdominal signs of cystitis, and I don't see why I should order a CT scan for the patient. All right? Good. Next question. You have a 68-year-old female with a history of chronic constipation. The patient presents with 1 week of increasing left lower quadrant pain, low-grade fever, and nausea. Her white cell count is elevated. She denies any diarrhea or recent travel. On physical exam, she has significant tenderness in the left lower quadrant. What's the most likely diagnosis? A, irritable bowel syndrome. B, colonic diverticulitis. C, ulcerative colitis. And D, colon cancer. What's the most likely diagnosis? A, irritable bowel syndrome. B, colonic diverticulitis. C, ulcerative colitis. And D, colon cancer. Doctors, what will you go for? Look at the age very well. 68-year-old. Constipation. 1 week history. Increasing left lower quadrant pain. Increasing left lower quadrant pain. And the answer is B. The answer is B. Dr. Jagdeep, why did you go for A? Okay. The answer is B. The answer is B. So you see, that is why it's good to go through these exercises, because it helps to, test your resolve. It helps you test, some of the concepts you've learned, right? I always say common things are common. You need to master your diverticulitis. You need to master all the causes of the lower abdominal pain syndrome. So colonic diverticulitis and the combination of left lower quadrant pain, fever, constipation should all prompt you to think about diverticulitis. What about irritable bowel syndrome? Remember that irritable bowel syndrome, which is A, does not present with fever. Neither will irritable bowel syndrome present with elevated white cell count. Okay, what about ulcerative colitis? Ulcerative colitis usually will present with diarrhea and rectal bleeding, and this patient does not have any of that. So you want to really be like, look at the things, the clues you are seeing in your board exam, the clue per question, and based on those clues, you can then use them to, build your narrative, and that can help you to select the correct answer. What about colon cancer? While it is possible, the acute nature of the presentation makes diverticulitis more likely. Assuming I had told you that this has been ongoing for a very long time, then maybe, and don't forget, assuming this was the patient's first bout of diverticulitis, I have a question. After the diverticulitis has been treated, what is your next best step? This one it's not on the board. So I want you to tell me, you have a patient, the same patient, you've made your diagnosis of acute diverticulitis. Now I'm asking you another question. You've treated acute diverticulitis, the inflammation is gone. After the inflammation has settled, what will you do next in a 61-year or 66-year-old patient who has been diagnosed with first case of diverticulitis? You've treated the diverticulitis. The patient is fine. You gave your metronidazole, you gave your Cipro, you gave the patient some bland diet. The patient is fine. What will you do? Beautiful, beautiful. I like that. Dr. Jackie Lou is getting it. She said, I'll do colonoscopy. Dr. Edward also got it right. Dr. Isaac got it right. Dr. Mukinde also got it right. So you see, we are building that muscle strength. We are building the things which help us to remember. So now you always remember, first bout of diverticulitis, we don't do colonoscopy during acute diverticulitis flare-up. No. But when the diverticulitis has been treated and the patient is now not symptomatic, what's your next best step? Do your colonoscopy. Beautiful, beautiful, beautiful. I like that. Now, you have a 23-year-old male who presents with right lower quadrant pain for 24 hours. This is simple. He reports nausea, but denies diarrhea and vomiting. His physical exam reveals tenderness in the right lower quadrant with guarding and rebound tenderness. His white cell count is elevated. In fact, this is a male, so I don't even see why I put a pregnancy test there. Probably I was tired, right? So the pregnancy test is negative. It's a male, so it should not even be in the question stem anyway. What's the most likely diagnosis? I think this one everybody knows. This one everybody knows. It's a simple acute appendicitis. Everybody should be able to pick up appendicitis even when they are sleeping. Okay, good. Let's go to the next question. So you have a 39-year-old male who presents with intermittent low abdominal pain and unintentional weight loss for the past 3 months. He denies any changes in his bowel habits or rectal bleeding. His family history is significant for colon cancer in his father at the age of 60. What's the next best step? A, stool occult blood test. B, start a high fiber diet. C, order a CT scan of the abdomen. D, colonoscopy. What's the next best step in a 39-year-old male? Intermittent low abdominal pain, unintentional weight loss over 3 months, denies any changes in bowel habits or rectal bleeding, but has a family history of colon cancer in the father at the age of 60. What's your next best step? What's your next best step? Dr. Hosna Taus says, I'm going to go for D. That is colonoscopy. Dr. Mutombo says, I'll go for D. Dr. Jagdeep also says, I'll go for D. And the correct answer is D. So now we're getting it. So colonoscopy, given the family history of colon cancer and the patient's symptoms, a colonoscopy is the most appropriate next step. Okay. What about stool occult blood test? This could be done, but would not definitely diagnose colon cancer. It may only show that there's blood in the poop, right? But it will not help us to diagnose it. The only way we can diagnose the colon cancer is to put, the colonoscopy, do the colonoscopy and then really go through the intestine and see what is happening in there. What about starting a high fiber diet? Yes, you may want to start a high fiber diet, but it does not address the potential serious underlying cause of the patient's symptom. Okay. And then order a CT of the abdomen. A CT scan might be useful, but colonoscopy is more definitive. And I see a question here. Dr. Kefa is asking, why not flexible sigmoidoscopy? Well, Dr. Kefa, flexible sigmoidoscopy was not even in your answer options. Okay. So you don't need to worry yourself so much about it. But if there was no colonoscopy and there was flexible sigmoidoscopy, I would go for that. But in this situation, I had A, stool occult blood test. B, start a high fiber diet. C, order a CT scan of the abdomen. D, colonoscopy. And I'll definitely go for colonoscopy. Okay, next question. You have a 29-year-old female with low abdominal pain and dysuria. On physical exam, she has suprapubic tenderness, but no costal vertebral angle tenderness. Urinalysis shows white blood cell and bacteria. What's the most likely diagnosis? A, acute pyelonephritis. B, cystitis. C, nephrolithiasis. And D, appendicitis. So, 29-year-old female, low abdominal pain, dysuria, no costal vertebral angle tenderness. So when you see that you are told that there's no costal vertebral angle tenderness, what medical condition are we ruling out? We are ruling out acute pyelonephritis. Okay, so pyelonephritis goes away. Urinalysis shows white blood cells and bacteria. What's the most likely diagnosis? Okay, so will you go for A, which is pyelonephritis? Will you go for B, which is cystitis? Will you go for C, which is nephrolithiasis? Or will you go for D, which is appendicitis? And I think everybody is going for B, B, B. Dr. Eugenia went for B. So let me see. What does the correct answer say? And the correct answer is B, cystitis. Low abdominal pain and dysuria with urinalysis findings, which are classic for cystitis. That's what you need to go for. With acute pyelonephritis, always remember it typically presents with flank pain and costal vertebral angle tenderness. And remember that none of those is present in this particular case. And what about nephrolithiasis? Kidney stone will cause flank pain, but not isolated lower abdominal pain. So, doctors, you see, we are just picking the issues one by one. And appendicitis, we know it will occur on the right side. And there are some cases of appendicitis where you may see positive urinalysis, but in a board exam situation, go for cystitis. Because remember that the appendix can be so long that it can be rubbing on the back of the bladder. Okay, it is only in those exceptional cases, but in a typical board exam situation, please go for your cystitis. Okay, next one. You have a 56-year-old female who presents with low abdominal pain, bloating, and altered bowel habits for 6 months. She denies any fever or weight loss. She has a family history of irritable bowel syndrome. What's the most likely diagnosis? Will you go for colon cancer? Will you go for Crohn's disease? Will you go for diverticulitis, or will you go for irritable bowel syndrome as well? This has been ongoing for 6 months. Bloating, no weight loss. So when you see no weight loss, it should be telling you something. No weight loss should be telling you something, right? Because everything is screaming colon cancer, but no weight loss, no fever, and then a strong family history of irritable bowel syndrome. That should lead you to irritable bowel syndrome, because irritable bowel syndrome will cause more of chronic abdominal pain, bloating, altered bowel habits without alarm symptoms. So this question is basically testing your knowledge on whether or not the one who is taking this mock knows the alarm symptoms of abdominal pain, like fever, like lumps and bumps on the body, like weight loss. If those alarm symptoms are there, it makes irritable bowel syndrome less likely. But those alarm symptoms are not there, so it makes irritable bowel syndrome more likely, especially because of the protracted nature of this particular condition. Most of the time, with diverticulitis, we know it will have left lower quadrant pain, fever, elevated white cell count. Crohn's disease, where did we say Crohn's disease can typically present? Is it on the right or on the left? Crohn's disease, please, doctors, where will you usually see it? Is it on the right or on the left? Crohn's disease, will you see it on the right or on the left? Crohn's disease, please tell me. Most of the time, will you see it on the right or on the left? Crohn's disease. Will you mostly see it on the right or on the left? Beautiful. Dr. Jagdeep says right. Dr. Mukindi says right. Okay, so now that we've done all that, let's do a deep dive into low abdominal pain syndromes. Let's do a deep dive into low abdominal pain syndromes. Let's do a deep dive into low abdominal pain syndromes. A deep dive into low abdominal pain syndromes. Okay. So these are quick facts, and then we will take some of the common low abdominal pain syndromes and then break them down. Low abdominal pain, you have to always remember, can arise from distal intestinal tract, that is like, the colon, or radiate from the upper abdominal structures. Okay. Now, proper diagnostic evaluation will depend on history and physical exam to determine the suspected causes. And that is why I took you through all those 9 to 10 cases. Which one happened on the left? Which one happened on the right? Which one presents with, red flag symptoms? Which one not presents with red flag symptoms? Which of them should you be concerned about, requesting a colonoscopy right away? Which of them can you do other investigations before that? Okay. Now, so for you to do that, you should be able to pick up a lot of the history, a lot of the facts from the history. What about pregnancy tests? You have to understand that so far as the patient is a female and it's in the reproductive ages, doctors, don't even play with it. Make sure that you do a pregnancy test as part of your initial evaluation. Don't say, oh, I trust this patient. Oh, this patient says she's not pregnant. Please, for documentation purposes, even if the patient tells you, I am not pregnant, please, just as part of your evaluation for low abdominal pain in a reproductive aged female, make sure you get your pregnancy test. Now, the suspected pelvic causes may require further evaluation. And the genitourinary causes like cystitis, like pyelonephritis, we learned that they can present with dysuria or flank pain, and we need urinalysis and urine culture. Okay. When it comes to the scrotal exam, it is required in males with lower abdominal pain. So if you see a male with low abdominal pain, one area you don't want to miss is the scrotum. So far as there's a male with low abdominal pain, doctors, one area you don't want to miss is to do a scrotal exam as well. Let me say it again. While you are doing a pregnancy test for females in the reproductive age, for a male with low abdominal pain, please don't forget to do a scrotal exam. Okay. So, what about acute diarrhea? Usually, the presentation is low abdominal pain. It may be cramping. Acute diarrhea may indicate a self-limiting condition. So far as the person is having a diarrhea without any red flags, that is what you want to think about first in a board exam. Acute diarrhea. It could be viral. It could be bacterial. Okay. And most of the time, if it is viral, you want to do expectant management based on the illness, severity, and the risk factors. Okay. What about Crohn's disease? As I said, most of the time in a board exam with Crohn's disease, you want to look for a patient who is presenting with a subacute right lower quadrant pain with diarrhea. How will I differentiate that from acute appendicitis? Acute appendicitis is more acute. Crohn's disease is subacute. Both of them can be in the right lower quadrant, but most of the time with Crohn's disease, you also see associated diarrhea. Okay. Now, inflammatory bowel disease presentations can vary significantly, so you also want to pay attention to that. What about diverticulitis? Diverticulitis, unlike Crohn's disease and unlike appendicitis, usually will present on the left. But the last time we did something, we learned something, and we said there's a group of people in which diverticulitis can present on the right. Who can help me with that? We said there's a group of people, there's a particular ethnicity, there's a particular location where diverticulitis can be on the right. And it is common in those people. Who can remind me? Who can remind me? Just type the answer in the comment section. We said there's a group of people that diverticulitis, even though it usually occurs on the left, can occur on the right. Beautiful. Dr. Edward got it. Dr. Edward got it. Asians, and Dr. Jagdeep also got it. Asians. Beautiful. Beautiful. So that means that we are picking things up, and that makes me very, very happy. Okay, good. Now, what are the essential investigations? Complete blood count with differentials. If you suspect a gastrointestinal cause like appendicitis, like diverticulitis because white cell count to be elevated. Remember, pregnancy test for all women of childbearing age, and urinalysis if there is any genitourinary cause. Okay, and scrotal exam for males presenting with lower abdominal pain. Please don't forget that while you do your pregnancy test for females in the reproductive ages, don't forget to do your scrotal exam in the male. So, the memorable clues are Crohn's in the right, diverticulitis in the left. Okay, Crohn's in the right, diverticulitis in the left. Classic Crohn's is in the right lower quadrant, diverticulitis is in the left. Check pregnancy test first. Now, I'm going to give you some quick facts in a table form, and you can take screenshots or you can always come back to this video to evaluate it in a table form. Appendicitis. What should I know? What are the quick facts I need to know about appendicitis? Generally on the right. It can start with periumbilical pain and it will radiate later to the right lower quadrant. Usually in a board exam, look for that patient who has right lower quadrant pain and associated anorexia, associated nausea, associated vomiting. Occasionally, patients will present with epigastric or generalized abdominal pain, and that is if the appendix has ruptured and has caused peritonitis. So that is one key thing about appendicitis I want you to know. Periumbilical pain starts that way, then it becomes localized in the right lower quadrant, usually associated with nausea, anorexia, and there can be vomiting, appendicitis. Okay, what about diverticulitis? Generally on the left lower quadrant, although right-sided symptoms are not uncommon, and we learned that that can happen in Asians. What are the clinical features? Pain is usually constant and present for several days prior to the presentation. The patient may also have associated nausea and vomiting. So you may have associated nausea and vomiting with right lower quadrant pain and appendicitis on the right. Then you can also have nausea and vomiting with associated left lower quadrant pain on the left in diverticulitis. Okay, good. What about nephrolithasis? Nephrolithasis can occur on both the right or on the left. So it can happen on either side of the abdomen. Pain is the most common symptom and it varies from mild to severe. Generally, there is flank pain, but they may have back or abdominal pain. Okay, so remember, nephrolithasis can be on the left or on the right. Crohn's is commonly on the right. Appendicitis is commonly on the right. Diverticulitis is commonly on the left. Diverticulitis in Asians is commonly on the right. Okay, and what to know? Cause symptoms as stone passes from the renal pelvis to the ureter. So as the stone is coming, you realize that the pain of nephrolithasis is usually described as spasmodic. It comes and goes. It comes and goes. It comes and goes. While the pain of diverticulitis is constant. Okay, so if you are confused, okay, the patient is presenting with left-sided abdominal pain. Okay, what am I dealing with? Am I dealing with diverticulitis? Am I dealing with kidney stone? And then you are told that the pain comes and goes. White cell count is normal. Then you think it's more of kidney stone. But pain is constant, left lower quadrant, white cell count is elevated. Think about diverticulitis. Okay, what about pyelonephritis? How will I be able to tell the difference between pyelonephritis and nephrolithasis? Pyelonephritis can also occur on either side because we have two kidneys, right? But usually pyelonephritis is associated with dysuria, frequency, urgency. There can be hematuria, that's blood in the urine. There can be fever, there can be chills, there can be flank pain, and there can be costovertebral angle tenderness. Costovertebral angle tenderness. One thing you don't want to lose sight of, and that is the key feature of pyelonephritis. Costovertebral angle tenderness. What about acute urinary retention? Most of the time, unlike appendicitis where the pain is on the right, diverticulitis where the pain is on the left, Crohn's disease, where the pain is usually on the right. Pyelonephritis, the pain can be either on the right or on the left. Nephrolithiasis, the pain can either be on the right or on the left. Acute urinary retention, the pain is in the suprapubic region. Suprapubic, okay? And there is low abdominal pain, discomfort, and the key thing is that the patient is unable to urinate. And most of the time, you want to pass a urinary catheter for these patients. And as soon as you pass the urinary catheter, they become so relieved that they can even sleep, right? So acute urinary retention, pain in the suprapubic region, present with low abdominal pain and discomfort, inability for the patient to urinate or to pee. Okay, cystitis, pain is usually in the suprapubic region as well. Associated with dysuria, frequency, urgency, and or hematuria. That's cystitis for you. You do your urinalysis, you may see positive nitrite, positive leukocyte, positive bacteriuria, exactly. So that is cystitis for you as well. I'm just taking advantage of this to just hit on the causes of low abdominal pain syndromes so that you can pick up some of the key things we need to pick up. What about infectious colitis? Infectious colitis can be on either the left or on the right. Okay? And the diarrhea is the predominant symptom. But the patient may also have abdominal pain, which may be severe. Now, one thing you need to know is when you are learning about infectious colitis, don't forget about Clostridium difficile infection. Okay? It can present with an acute abdomen and peritoneal signs in the setting of perforation. So if the infectious colitis perforates, then you are looking at a patient with fever, bod-like abdominal rigidity, rebound tenderness, on all those things. You are expecting those things. Okay, good. So that's infectious colitis. What about testicular torsion? Because remember I said that any male with lower abdominal pain, make sure not to forget your assessment of the testis for testicular torsion. It can begin in the lower abdomen and can be localized to side if lateral to the testis. So if the pain is on the right, most of the time the testicular torsion is on the right. If the pain is on the left, most of the time the testicular torsion will be on the left. Okay. Often it's associated with nausea and vomiting. So severe low abdominal pain, no fever, but nausea and vomiting in a male. Think about testicular torsion. Usually you see it in boys or adolescents. Think about testicular torsion. Testicular torsion. So, doctors, before we wrap up, I want to give you this assignment. Maybe one of these days I will take advantage of it and also discuss that. Because in these sessions, I want it to be quick reviews, okay? So that we can get some take-home points. But I need you to also revise low abdominal pain and pelvic pain in females alone. Low abdominal pain and pelvic pain in females alone. So that is the assignment I want to give you. Low abdominal pain and pelvic pain in females. Make sure that you've mastered ectopic, you've mastered Metzl-Schmerz, you've mastered pelvic inflammatory disease, you've mastered your ovarian torsion, you've mastered all those causes of low abdominal pain in females. Today we just did low abdominal pain in general. One day I think we should really take time and do low abdominal pain in females so that we will know how to break it down. I have a question. Has this session been helpful, doctors? Has it been helpful? Because it was necessary that I repeat. Has the session been helpful, please? Has the session been helpful? Those on Facebook, those on YouTube. Has the session been helpful? Yes or no? Beautiful, beautiful. So Dr. Husna says yes. So please, I'll be very glad. Those in MedCognito, please do this assignment. Low abdominal pain and pelvic pain in females. And you can even send me a WhatsApp voice note in the group. Okay? In the group. A voice note, Dr. Jagdeep, Dr. Eugenia, Dr. Mukende Butulo, please, all of you, do the assignment and send me a voice note in the private MedCognito WhatsApp chat so that I can evaluate it and see. All right. So for those who are not in MedCognito yet, we still encouraging you. MedCognito is here to support you. MedCognito is here to help you. Okay. MedCognito is here to make sure that your exam preparation is smooth. So please do this assignment. You can also text it to me in the Facebook group as well if you're not in MedCognito yet. But I'll suggest that, take advantage of what we are offering you. And remember that our promo is still ongoing. So instead of 1,997 for 6 months, you get access to everything in MedCognito for 1,599. Okay, for 6 months. You can pay it in installments or you can pay it one time. All right, please. So please, I want to see your answers, your review. I want to really see your review in the comment section of the WhatsApp grouping of MedCognito. Okay, so as I said, the promo is still ongoing. It will be ending, I think, in a day or two. So doctors, take advantage of it. You can even make monthly payments, or if you want to make it one time, just do it, and then we'll take it from there. Now, some also may want to touch base with me right away. So when I say you can take advantage of it, instead of 367, which is our original price, you can get everything for 299 every month for 6 months. Okay, or instead of doing the 5-month payment, which is $440 every month, you can make it as $359.99. Or instead of the $550, you can make it as $437. So I'm just letting you know that you have all these options at your fingertips. And maybe you may want to touch base with me personally. This is my number. This is my private number. This is the number I talk to everybody on. And this is the phone. It's +1 306 891 5649 +1 306 891 5649. So Dr. Hosner says, I'm not in the WhatsApp group, Dr. Brony. Well, Dr. Hosner, to be in the WhatsApp group, you should be a registered member of MedCognito. So that's why I'm putting the link in the comment section so you can use it to register. Okay? I'm putting the link in the comment section so you can use the link to register. Okay. So you can use the link to register. So I've put it in the comment section. Just click on it and just register. Okay, so doctors, thank you very much for spending your evening with me. This video will be available to you on YouTube and on Facebook. Just go in there, use it for your reviews, and then let's take it from there. Okay, thank you very much for spending your evening with me, and I'm hoping and praying that this quick review was something meaningful to you. You can also share it with your friends as well when the stream ends so that they can also go through it. Thank you very much. Enjoy your evening and see you in class. Bye-bye, 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 bye-bye.